The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're fortunate this month to be able to talk to Dr. Glen Lau from Pediatric Urology Division at Primary Children's. Welcome back, Glen.
Glad to be here. Thank you.
You know, I'm not sure how I decided what order to talk about voiding. It may have made sense to start here. We wanted to talk this week about voiding dysfunction generally and daytime wetting. And it might have made sense to go the other direction, but it is what it is.
I think that nocturnal enuresis, I will say, is probably my most common, oh, by the way, consult when I see a kid for an undescended testicle and, oh, by the way, what's the bed? But no, I think there might be some overlap, but I think the order is fine.
Okay, all right, we'll dive right in. In the past week, have you developed financial interest that you need to disclose?
Nope, nothing exciting. Yeah.
Okay, well then let's jump in. I wanted to ask some questions about how bladders and voiding work in the first place. So when should we expect a child to have control of his or her bladder?
Obviously, there's kind of a spectrum there. You know, you'll hear the anecdotal things about girls kind of toilet training earlier than boys, which there actually seems to be some evidence for. But, you know, typically like the nighttime type stuff, you know, we'd start to worry about it a little more when they're approaching school age. So probably 5-ish is when we would expect a developmentally normal child to be continent during the day.
It seems to me there are a couple of issues. One is the ability to void on command. And the other one is that you can delay voiding. It's what we called at my house growing up a trip bladder. You know, can you wait till the next rest stop before you empty your bladder?
And we look at it, I think, in that vein with there being issues of filling and, you know, the bladder kind of relaxing and having the capacity to fill at low pressures. And then issues of emptying, right? Our inability to relax the sphincter and generate a contraction that's going to empty adequately.
And do those ever work at cross purposes that you're relaxing one thing while flexing the other?
Yeah, so in patients with neurogenic bladder, which I know we'll talk about a little later, there is what we call detrusor sphincter dyssynergia, which a normal voiding sequence is that we relax the external sphincter, which is under conscious control, and then the detrusor, which is under parasympathetic control, contracts to push the urine out. In neurogenic bladder, sometimes we will see that the opposite happens, that there is a spinal reflex that actually causes the sphincter to contract when a bladder contraction happens. And that's involuntary, but in some children, you know, in order to stay dry, they will consciously contract that sphincter and end up with kind of a difficult time relaxing when they're supposed to fully empty their bladder.
Okay, that's actually very helpful. So when you suppress the urge to void, I'm guessing that's a very short-term thing for most people.
Correct. It's not a permanent fix. And so if you hold it, quote unquote, long enough, then there is a separate sacral micturition center. So the main control is in your pons and the brainstem in the pontine micturition center, but there is the sacral micturition center, which is basically a reflexive voiding. Mm-hmm. And so what'll happen is once the signals get strong enough, then that sacral micturition center kicks out a signal for a reflexive bladder contraction. You know, that is probably when we see most of the, you know, kind of painful type bladder spasms and those types of things.
What I sometimes refer to my patients as the reset button.
There you go. That's right.
That, you know, a bowel has a lot of capacity. If you suppress the urge, it just gets bigger and bigger and bigger. But a bladder doesn't have much room to go.
Correct. Yeah. And, you know, you can see some big problems if it is allowed to go too long. Yeah.
Okay. Well, let's talk about some common causes of voiding dysfunction. Is there such a thing as an overactive bladder? What does that mean?
There is, yeah. So overactive bladder is an actual diagnosis, and that is, there are other terms like detrusor instability and things like that. An overactive bladder is basically a bladder that is hypercontractile. So the detrusor muscle will basically contract before it would be time to void. And so that's something that we see both in children and adults. And in kids with, daytime wetting, that can be the cause, or it can be one of a few different causes of what a child has going on.
And is that an acquired condition, or is it a tendency that someone has to?
It can be both. So, if you are a chronic holder, then the bladder basically just can become a little trigger happy. And when you have those reflexive type contractions going on, then that would be, an element of overactive bladder. But we definitely see patients who are anatomically completely normal, who do void very regularly and do not have any issues relaxing their sphincter, who just have an overactive bladder.
Okay. And we'll come back to dealing with that in a minute. We talked a little bit about postponing voiding, which is one of the more common things that we probably see. What about incomplete emptying?
So incomplete emptying is also something that can be both intrinsic, sometimes it's an issue of subclinical neurologic issue, or more in adults, more often we would see like a diabetic type cystopathy where they don't have the same sensation and the bladder just kind of keeps getting bigger and bigger. But it's also something that can happen when we have prolonged holding behaviors and the bladder just kind of expands to a point where those muscle fibers really just can't kind of come back in contact to contract. So that's one that can be really difficult to deal with, because if they've gotten to that point, then medications tend not to really help out.
Okay. It seems to me also on a smaller scale that some kids are just too hurried in the voiding process and relieve the pressure and then get on with their life.
Yeah, and I think that, when we talk about kind of treatment, that's something that we try and address up front with kind of our standard urotherapy, which we can talk a little more about.
Okay, I guess that's what's known in business as a spoiler, so we'll hold on to that. Tell me about what comorbid conditions I should be paying attention to.
Well, like we alluded to with the nighttime stuff, diabetes is one. You can check a urinalysis and see. We always also check a urinalysis and would send a culture if there's any suspicion for infections. Constipation, once again, that's a huge one. It's probably somewhere between 25 and 50% of kids who have lower urinary tract dysfunction also have comorbid constipation. And that's probably something that some of us get a little aggressive about because we're convinced that they're constipated even when they maybe aren't. But,
it's an interesting conversation sometimes, though, because in talking to both kids and their parents, sometimes talking through what constipation actually is, because, he moves his bowels every 6 weeks, but that's what he's always done. And so it probably deserves at least some discussion.
Yeah, and I always do tell parents, even if they are adamant that their child is not constipated, if it's an 8-year-old, it's probably been a number of years since you've actually checked and seen what things look like in the toilet. And I just tell them, maybe just pick a 3-day period where you just, pick another weekend there where you just kind of keep track and see, are they skipping days? Is it super hard and pellet-like? Bristol stool scale is a useful thing in those cases, because the children sometimes find it funny if they don't find it gross. You kind of glean some information on that.
Yeah, I do think that sometimes a conversation about, but what if it helps, usually opens the door. All right, so let's talk about the risks of non-treatment. Obviously, the number one risk in my mind is the social risk. If kids are unable to control their bladder, it becomes obvious.
Correct. Yeah, and I think it's more painfully obvious probably to the patient than anyone else around them, but it is something that can really affect self-esteem and lead to some anxiety and problems in that department. And this is one where I also definitely try to normalize it for kids and make sure that they don't feel that this is something that's a life-ending issue, and that it is actually more common than they think.
Right. I mean, by analogy, I often tell patients, you would be amazed how many of your classmates are constipated. Nobody's talking about it,
Right. Yep.
but you would be amazed. And that's why we're having this conversation. Who's at risk for kidney damage from voiding dysfunction?
So patients who have infections are at risk for damage to kidneys. And then, in extreme forms of voiding dysfunction, there's the eponymous Hinman syndrome, or we would call it like a neurogenic bladder, where they've gotten so far removed from being able to empty that they're actually pushing, have a very, very high pressure bladder and incomplete emptying. We run into those periodically, and they're very difficult because they have a lot of them already, gone into some form of chronic kidney disease, and in extreme forms, end-stage renal disease. So I would say that's one thing. If I'm concerned about the fact that their voiding dysfunction seems somewhat extreme and poorly controlled, it's always reasonable to get an ultrasound and get some upper tract imaging to see what's going on there.
Very helpful. So in talking about evaluating this, I'm going to sort of jump ahead on the history because I think you've mentioned that, and come back to this idea of avoiding diary. And it sounds like similar sorts of things to what we talked about last week with the bedwetting, how much a child drinks, how often they empty their bladder. And you would measure volumes where possible.
Yeah, I think that's helpful both for us to kind of get an idea, but also to give an idea to the parents as to what their child is actually doing.
Is it helpful to get a sense for how a child voids?
I think in some cases, and I think it's easy enough to ask for a boy, for instance, is this something that there's always a mess when you go in afterwards and you feel like he's not getting anything into the toilet, because that could be like a meatal stenosis type issue.
Mm-hmm.
In girls, we run into occasional patients where they will also have a deflected stream. It's pretty rare, but it's possible. So that's a reasonable thing to ask.
Deflected from adhesions or?
Labial adhesions is one thing. Every once in a while, we will see kind of like just an anterior deflected stream. And then sometimes, they will also complain that there's always wetness afterwards. And so that could be that in a girl, they're kind of posturally not leaning forward, and they get basically like vaginal reflux of urine that then just kind of empties into their underwear. And so, those are ways to also kind of assess what might be going on as far as posture too.
All right. As you mentioned before, this may be somebody who has tight phimosis. It would be good to know because they probably have high volume wetting, but at least some dribbling.
Yep. Definitely important to do a physical exam.
Okay. Urinalysis looking for
anything abnormal. So anything suggesting infection, obviously any leukocytes. I do like personally sending it for microscopy, but a dipstick is probably fine for just the kind of quick and dirty. You're checking for protein, that could lead to maybe looking a little more into the upper tracts there. Definitely looking for sugar, so if there is glucose in the urine, then that's a whole different kind of consult. And then we talked earlier about specific gravity. If they're super dilute, there's always the possibility of diabetes insipidus or just, kind of podomania, drinking a whole lot. So
Sure. And I think putting that into context is often very helpful because I think there's often not really great communication about how much a child is drinking and how much they're voiding.
Correct. Yeah.
And school can be a challenge there because I don't know that bathroom passes are always super liberal.
Yeah, and we bring that up when it comes to our kind of standard urotherapy, if you will, because a lot of kids, they're kind of, I don't blame teachers. If you have 30 kids constantly wanting to go to the bathroom at the same time, then that can obviously be a little disruptive. But we do find that to be a problem. That's something that can be elucidated in the history a little bit as well, kind of when interacting with the parents. You can ask them, listen, do you have to remind your child to go to the bathroom? Do you find that they're distracted, playing video games, and then they, kind of all of a sudden have to rush to the bathroom? And then also, what goes on at school? How many times do you go at school? Do you ever go at school?
Right.
And those types of things,
And I find the answer to that optimally is rarely.
Yeah, that's right.
Which is a cross purposes with the whole hydration thing, but that's a whole different discussion. Okay, so treating this, obviously we want to deal with any potential comorbid conditions. So do you do any mindfulness training, or I guess what I mean by that more is thoughtful voiding?
Yeah, so what we typically do kind of as a first line is what we would call standard urotherapy. So that would include number one, avoiding bladder irritants. So from a dietary standpoint, caffeine, chocolate, spicy foods, those types of things we try to cut out of the diet because they really can. And you'd be surprised how many kids, slip a rock star in there every once in a while.
I would not be surprised because I'm
Yeah.
amazed at how much caffeine kids consume and don't think about it much.
Right. And then also we talk about voiding posture. With girls, it tends to be we need to, kind of sit up and maybe a little forward. We need to make sure legs are spread, even though we're always taught to kind of keep them together, right? And then be nice and relaxed, kind of keep your feet on the floor. And if kids need, something to kind of support their feet so that they're not dangling, and then that way they're kind of in a more relaxed, normal position. And then in boys, a lot of kids have kind of elastic waistbands, making sure that that is actually pulled down so that they are not obstructing their flow.
Yeah, sure.
And then lastly, with that standard urotherapy, we recommend timed voiding, which is basically going pee on a schedule. And that's something that we usually recommend every 2 to 3 hours while they're awake. We don't recommend they wake up at night to go. And the school issue there often comes up if it hasn't already. And we actually give a timed voiding note for school that says that they should actually get reminded and sent to the bathroom as opposed to just have an open note that lets them go when they want, kind of thing.
I know people have talked before about the notion of a double void before, that you empty as much as you can and then do something as a diversion and try to push the rest out. Is that helpful?
Yeah, so it depends on the patient. So if they actually, and we didn't talk about imaging workup, but we oftentimes will get an ultrasound just to check upper tracts and then also check the bladder, and we would get some pre and post void images of the bladder to see how well they're emptying. In those kids that are having an issue emptying, then double void is actually something that's pretty reasonable to do. Yeah.
Any other radiography that we had to think about doing besides?
So an ultrasound is, as I'm sure on all of your PED certifications, that's usually the first answer, right? That's going to be kind of our first line thing. But if they do have infections, particularly febrile urinary tract infections, then we would probably consider a VCUG. Every once in a while, if parents need proof that their child is constipated because you are convinced and they are not, then you could get a KUB as well, just to kind of show the stool pattern in there.
Okay. Are there times you use medications, and if so, which ones?
Absolutely, yeah. So, the one FDA approved medication for daytime urinary incontinence for a neurologically intact child is oxybutynin. So that tends to be our first line, not only because it tends to work probably better than most things, but also because it is the one that's actually covered by insurance. And then, there are other formulations. That's the only one that's offered in liquid form, though. So kind of have a difficult time finding other anticholinergic medications like Vesicare, Sanctura, Detrol, those types of things. You can kind of go back and forth between a few of those medications. There's also a newer class of medication called a beta-3 agonist, where muscarinic receptors are what causes contractility of the bladder, and that is a parasympathetic arm of things. There are beta-3 agonists where it stimulates those adrenergic receptors in the bladder, and that causes relaxation of the bladder. So that's a whole different class of medications. And mirabegron or Myrbetriq is the main one there. That is not FDA approved for kids with non-neurogenic overactivity. We've gotten it approved for kids before. So that's an option there as well.
Going back to oxybutynin, how do you use it? Do you 3 times? How do you?
Yeah, so if it's an older child that can take pills, I do prefer an extended release. So, once a day formulation of that. If it's a younger child, I'll usually just start it out twice a day at 0.2 milligrams per kilogram with a max dose of 5 milligrams. The reason being is that it can be given up to 3 times a day. I just find that as a parent myself and having dealt with a lot of other parents that feel similarly, it's hard to keep up 3 times a day, but twice a day is pretty easy. So we just do morning and night to kind of start out with and see how we do.
I saw reference to biofeedback. Is that something that's been in your practice?
Yeah, so when we're getting to kids who are kind of refractory to medications, and particularly ones that have a real problem with emptying, so they have a hard time relaxing their sphincter, the biofeedback is actually a pretty nice tool. We do it in our office with our nurse practitioners, but they can also go to a pelvic floor physical therapist, which will refer them to those often because they can also work on posture and some other kind of aspects of musculoskeletal stuff. But biofeedback, yeah, in the right patient where they are old enough to kind of participate. So usually we would say somewhere around 7 or 8, and B, where they have a problem with emptying. So we see that there are actual decent residuals. That's definitely a treatment form that we use.
Which of these kids end up being candidates for surgery?
So those are the refractory ones to medications. There are definitely surgical options, but they are not FDA approved in kids. And so, first of all, I would say that before we move on to surgery, that's when we would probably do actual urodynamics studies on these kids. It's a pretty not fun, somewhat invasive test where we have a catheter in the bladder and a catheter in the rectum. And, for a sensate child, that is not a pleasant experience. But if we're thinking about doing something surgical, then I would want the information that we glean from that, which would include kind of what their capacity is, whether or not they have that kind of actual urodynamic proven overactivity of the detrusor muscle, what their ability is to empty. It also can tell us about reflux and other things. So there's a lot of information you can glean, but we kind of save those for the bad actors.
Sure. And again, this can be something that can be very intrusive in someone's life.
Absolutely. Yeah.
Anything else we ought to be thinking about with voiding dysfunction? We'll talk more about neurogenic bladder next week, but
for sure. Yeah. I think that, if you have a kid that is school age and is wet, whether or not that is secondary, it started later on, or it's a primary thing that has never really, been something that they've been successful at being dry. Trying those kind of first line things, I think from a primary care standpoint is totally reasonable. But yeah, we do have those bad actors that really require kind of an escalation of care, and we're more than happy to see them and work with them.
Terrific. And as always, collaboration leads to better care.
Yep, you got it.
One thing I've always admired about your group in general is that you've always been really good about, when I have a question, that you're able to talk me through things in a logical, rational way, and I appreciate that.
Absolutely. Yeah, we got that doc line. It's open.
All right. That is a good thing. Well, next week, if you're willing, we'll talk about neurogenic bladder, which I understand is something that's been a particular interest to you.
Yeah, absolutely. Excited to talk about it.
Great. We'll do that. Please send your questions to questions@vcurb.com. We'll look for those in a couple of weeks. Glen Lau, thanks for spending some time with us again.
Absolutely.
All right. See you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.